Welcome to the ATOMIC2 site training. We're just going to go over several things today. Just to talk to you a bit about the organisation of the trial. So we're sponsored by the University of Oxford, and the trial is managed by the Oxford Clinical Trials Research Unit. We've got Timothy Hinks, who's with us today as Chief Investigator. We've got various sources of funding for this trial to go ahead. One of the important ones is Pfizer, who are providing the study treatment to us at no cost. With regards to the trial management team, so I'm Lucy Curiton, I'm your trial manager and your first point of contact with any questions or problems. Tim, as I've just said, as CI, and we've got a team of statisticians who will be doing the analysis. We've got a very expert quality assurance and drug supply person called Joanna, and we've also got a trial steering committee and a data safety monitoring committee that oversee the study and make sure we're doing things properly.
Hi, thank you. So azithromycin is a synthetic macrolide antibiotic, but it's got many properties. It's been used in SARS and a third of cases of MERS-CoV, but there's no randomised trial data in any coronavirus to date. However, it's got, beyond its antibacterial properties, it's got antiviral and anti-inflammatory properties. The antiviral effects are important. We know that in vitro it reduces rhinovirus replication, that's the common cold, by inducing type 1 and type 3 interferons. It's also come top in the hit in drugs which should be repurposed for Zika virus infection and enteroviruses. It's also got activity against Ebola and SARS, influenza A, and we know it reduces exacerbations in asthma through unknown mechanisms. So it's the anti-inflammatory effects we're particularly interested in this study because respiratory viral loads have fallen by day 5 to 7, and by the time people present to hospital, it's not usually a viremia which is the problem so much as an over-exuberant inflammatory cascade due to a late increase of interleukin-1 beta, IL-6, IL-8, TNF and other cytokines. And that's associated with something called HLH syndrome, which involves many inflammatory cells being recruited to the lungs. So the rationale for using azithromycin is not as an antibiotic, it's to try and damp down that late over-exuberant inflammatory cascade. And azithromycin suppresses activation of granulocytes and lymphocytes. It suppresses those same cytokines I mentioned, IL-1 beta, IL-6, TNF, IL-8. And beyond its known efficacy in asthma and COPD and cystic fibrosis, where it may be acting as an antibiotic, azithromycin is also effective in obliterative bronchiolitis, post-lung transplant bronchiolitis and diffuse panbronchiolitis. These are conditions which aren't driven by bacteria, and it's its immunosuppressive properties which are effective, particularly with Japanese diffuse panbronchiolitis, which used to have a 10 to 20% 10-year survival. It now has a 90% 10-year survival due to azithromycin. So the question is, can these anti-inflammatory properties be used to treat coronavirus? So this is a study flow diagram, and to highlight, there are 2 other national studies of azithromycin which are planned. Principal will be starting roughly the same stage. That's in primary care using a telephone diagnosis of coronavirus. These are much milder patients. The recovery study, I'm sure you're all familiar with. People who are admitted to hospital with respiratory failure will be eligible for recovery, and they'll be receiving just 3 doses of azithromycin. ATOMIC2 is entirely complementary to these 2 studies. We take people who are presenting to hospital but are deemed well enough for initial ambulatory care, and so they're discharged. That means they're not eligible for recovery, they are eligible for ATOMIC2, and once that decision to admit has been, decision for ambulatory care has been made, then patients will be informed about the study, consented, recruited and randomised. And they'll either receive usual care or 2 weeks of azithromycin 500 milligrams once a day. The follow-up in most patients is a telephone follow-up at day 14 and day 28. There will also be checks on the hospital electronic patient record and the NHS death registry prior to those phone calls. And we expect 1 in 5 people to be readmitted. For those people, there will be an additional case report form to fill in on the day they're admitted, and daily thereafter whilst they're an inpatient. Those forms can be done by telephone. I'll show you more about those in a minute. So this is just to summarise the differences and the complementary characteristics of these 3 studies: Principal in primary care, ATOMIC2 ambulatory care and recovery people who've been admitted to hospital. So vis-a-vis study objectives, we're testing the hypothesis that azithromycin 500 milligrams once daily for 14 days can reduce death or respiratory failure in COVID-19. It's a multi-centre study taking place in 15 sites across England, Scotland and Wales. It's prospective, open-labelled, so there's no placebo. This means it's a very simple, pragmatic study. And we're taking people who are presenting with a clinical diagnosis of COVID-19, not necessarily PCR proven, and they're not being admitted at initial presentation. Next slide. So the objective is to compare the effect of azithromycin in those people with clinical diagnosis. And we're looking at 28 days from randomisation. That's the primary objective. There are several secondary objectives which you don't need to memorise, but just to say that one of these is to look at the subset of people who have a PCR confirmed diagnosis of COVID-19. That's to check that our study is generalisable to people who are PCR confirmed. And so we're providing the chance to do swabs to test PCR presence of SARS-CoV-2. It doesn't have to be done in 100% of patients, but we do need a reasonable proportion, perhaps 80% of patients, to have a throat swab. We'll talk more about those in a minute. We're also looking at all-cause mortality, the proportion progressing to pneumonia or to severe pneumonia, differences in the peak severity of illness using a 9-point ordinal score, safety and tolerability, which we expect to be good, as azithromycin has an excellent safety profile. And there are some exciting mechanistic analyses of blood and nasal biomarkers. They won't be available on every patient, but it would be great if we can get them on a reasonable proportion. Next slide. So the study design is to look at 800 patients, but after the first 100 patients, there'll be an interim analysis to determine whether this study is viable and to check that the power calculation is correct. It'll take 2 to 6 months depending on recruitment rate. Follow-up's 28 days, the comparator is usual standard care, and the setting is adult patients being assessed in NHS hospitals. These are the inclusion criteria. We're taking any adults who are being assessed by the clinical team as appropriate for initial ambulatory management. So that's not the site investigator's decision, although you might be part of a clinical team. We're taking a clinical diagnosis of highly probable COVID-19. So that's if the attending team feel that the most likely diagnosis is coronavirus and that's what you're treating them for. They might have other comorbidities and problems, but they need to have a highly probable diagnosis of COVID-19.
So the diagnosis needs to be symptom onset within the last 14 days. It's possible in some cases they may have had a PCR test before that, but we're only taking people whose symptoms have started within the last 14 days.
There's a catch-all that we wouldn't include people who you feel are inappropriate, so anything in the medical history that might put the patient at significant risk if they were to participate in the trial, but we can't foresee many of those. They do need to be able to understand written English. That's because the informed consent process is happening rapidly in A&E. The study's been designed rapidly, we don't have written translations, and there's telephone follow-up. The outcome for this depends on telephone follow-up. So it's really important we don't have people who we can't follow up accurately at day 14 or 28 due to their written English. There are not many exclusion criteria. The key thing is if they're allergic to the drug, we're not going to give it. Also, if they're on another macrolide. So to run through the exclusion criteria in detail, if they've got known hypersensitivity to azithromycin ketolides, that's telithromycin or roxithromycin, or to any other macrolide, so erythro or clarithromycin. The compound is made up in something which contains soy protein, so exclude people with severe hypersensitivity to soya or peanut allergy. There are some rare inborn errors of metabolism which make people intolerant of sugar. This is unlikely to affect many patients. Currently on a macrolide, this is important because these other macrolides can have similar anti-inflammatory effects. And so if they're being diagnosed with COVID and a possible community-acquired pneumonia and sent home on clarithromycin, then we can't really enrol them in the study. So that's an exclusion criteria. So we're not requesting people have their troponins checked, but if they're diagnosed as having significant myocarditis associated with their COVID-19, then we will exclude them.
Using an ECG, we're going to exclude people who have a QTc longer than 480 milliseconds.
Likewise, we're not requiring you to measure electrolytes, but most people will be getting electrolytes measured. If they're profoundly hypokalemic with potassium less than 3.5 or another significant electrolyte disturbance, then we would exclude them, just again for the theoretical risk of QTc prolongation. We'll exclude people with clinically relevant bradycardia or ventricular tachycardia or unstable severe cardiac insufficiency. And lastly, we're excluding people who are currently taking hydroxychloroquine or chloroquine. So over to Lucy to talk about screening and recruitment.
Thank you, Tim. So screening and recruitment, I've put this first line in red because it's so important. Because ATOMIC2 is a clinical trial of an investigational medicinal product, it's a requirement from the MHRA that eligibility of a patient must be confirmed by a medically qualified doctor. In addition to that, the patient must be able to receive the first dose of azithromycin within 4 hours of randomisation. So if you think a patient can't achieve that for whatever reason, then they shouldn't be put into the trial. And what we actually ask you to do is when you're with the patient, once they've been randomised, if they're allocated study treatment, we ask you to watch them take the first dose while they're still with you in hospital. You'll be screening patients based on a review of EPR and their medical notes and various other examination findings. Anyone considered for ATOMIC2 should be screened even if you don't randomise them. So I've put here the link to the REDCap system on the bottom. However, this is already uploaded onto the iPad. So as soon as you log into the iPad, the icon will be there on the screen for you, and that will take you straight into screening a patient. The screening log is electronic, and it's really important to collect information about patients who haven't entered the trial. So as Tim spoke about earlier, it's really useful for identifying any problems with recruitment, whether that be patients not speaking English or any other problems that crop up as an area of difficulty. It's also really important so that we can report our trials really transparently and show that we're not only giving information about patients that were actually randomised. So this is the screening log as you will see it on REDCap. So for the site, there's a drop down that will just have your site where you're recruiting, the date of screening, which you will put today, first and last initials, that's of the patient, not of you. You will also put in their age and their gender. So giving you some screenshots here just to really get a feel of the REDCap system. Not everyone might have used this before. So the next part of screening will be go through the inclusion and exclusion criteria as Tim has gone through. So each criterion has its own button which you would click yes or no. So it's really important if you do go through and you do reach an eligibility criteria to which would exclude the patient, don't just abandon the form or back out of it and just think, okay, well that never happened, we don't need to randomise this patient. Always go through to the end so that we can see the reason that the patient isn't going into the trial. So that could be because they're not eligible, so they don't meet the criteria, or once you get to this screen, is the patient willing to consent? They might get this far and say no. That's absolutely fine. There's no pressure for them to go into the study. So if they do say no, again, don't back out of the form, just complete it, click no, and then click what the main reason, the closest resembling reason to why they don't want to go into the trial. Sentence that I put in red a couple of slides ago. So where it says eligibility confirmed by, the name in this box must be the medically qualified doctor, and they must have seen everything they need, any test results or review of notes to have made that decision in an informed way. So the name in that box must be a medically qualified doctor. And then if you're satisfied that the patient is eligible, you will then press progress to randomisation and submit, and then it takes you on to consenting the patient. Informed consent, I'm used to doing on paper, so it's quite new to me to have this done electronically. So the REDCap system takes you through it. It's really important that the patient is, of course, deemed eligible before you can start consenting them. And until you have their consent, no study procedures or treatment should commence. As part of consenting, you should be explaining the exact nature of the ATOMIC2 study and what is involved, including the fact that this might not benefit them personally. You should ensure that the patient had received the patient information leaflet and been given time to think and ask questions. So usually we would like the patient to have the patient information leaflet for about 24 hours so that they've got long enough to think about the trial and ask any questions. However, due to the nature of the study and the disease, they'll only have a couple of hours. So what we do is send out a stack of hard copy patient information leaflets which they can read through while they're waiting. You should also let the patient know that they can decline to participate and they can withdraw from the study at any time. They don't have to give a reason and it won't affect their medical rights at all. Part of consenting on the REDCap system, you do need to put in their contact details. So that's their first name, last name, NHS number, date of birth and age. We also record GP details. Now that's really important because it was a requirement from the ethics committee that we send the patient's GP a letter to let them know that they've taken part in the trial. And just to let you know that we send those out centrally, that's not something you need to do. Also make sure that their email address is correct, because once consent is completed and the form is complete, a PDF is sent of the form to the email address that's recorded on there. If they don't have an email address, please try and get one from a next of kin or someone that can receive the consent form on their behalf if they're happy to share that. Also make sure all telephone numbers are correct because the whole study is based on the 14 and 28-day outcome telephone calls. So once the patient's eligible and they're definitely happy to continue, you can then go through the consent process. So if you're doing it on the iPad, give the patient the iPad so they can read each section, or if you're doing it on a PC, just angle the screen towards them so they can read it for themselves. In addition to that, it is good practice though to read out each statement aloud to the patient. So once you've discussed every statement on there, you will ask the patient to check the box if they agree. So normally on a paper consent form where the patient would initial the box, this will literally be them either clicking or pressing with their finger to check the box that they agree. Tim's going to talk to you about optional samples later on, but this is a section at the end of the consent form that where they agree to give the optional samples. They can say no to this, that's absolutely fine. So at the end of the consent form, they will put in their full name. It's really important that they do that themselves as it's taking ownership of the consent. Where it says add signature, there is a green box with a plus sign. Once you click on that, it opens a black box, which you will sign either with your finger, like you do when you get a delivery of a parcel, or you can also do it with the mouse. Once the patient has signed, it's passed back to the person who's taking consent, so the research team. Again, you will put in your name and then add a signature as a countersigning of the consent. It's important to remember that when you're signing on a computer, it's the legal equivalent of your written signature, and it should be treated as importantly as you would do for your written signature, so it's no different just because it's electronic. Once you've consented the patient, as I said, a PDF of the completed form will be sent to the email address. Also, because ATOMIC2 is a CTIM, you must ensure that in the patient's medical notes there is a note that they are taking part in the ATOMIC2 trial. Also, in addition to this, it's really good practice to have a copy of the consent form in there. Not only is that a requirement, but also these patients are more likely than perhaps the general population to be admitted to hospital. So it's important that when they're admitted, you can see straight away that they're taking part in the trial. Once you've completed consent, REDCap takes you straight through to the randomisation page. So again, I'll just go a few more screenshots. It's really a very, very simple system to use. It's almost foolproof. So once you're into the randomisation page, it will just ask you once again to confirm eligibility. So you really can't get away without confirming that. And confirm that the patient doesn't meet any of the exclusion criteria. You will then just be asked to put in a couple of things that we need for the stratification, which is to do with the analysis and randomisation of the trial. And then you will just click again that the patient has consented, and you'll put today's date. Put your own name in for whoever is taking randomisation, is doing randomisation, and that doesn't have to be the same person that consented the patient. And again, you'll put in the medically qualified doctor's name that confirms eligibility. So once you click on submit, it will then randomise the patient. to whether they're going to be taking study treatment or usual care. Now, it does take up to 30 seconds to randomise the patient, which will seem like a lifetime when the patient is stood in front of you, but please don't refresh the page, don't go back, just let it do its thing, and it will eventually then come through to this page to say that the patient has been randomised. It will let you know the treatment allocation, whether that's study treatment or usual care, randomisation number, and will send us an email to the ATOMIC2 team to say, congratulations, you've randomised someone, and it will send you an email as well. So once this is all done, you can then complete the baseline questionnaire and dispense study treatment if that is what's been allocated. So I don't want to bore anyone to death with more screenshots, so I haven't got screenshots of the following CRFs. However, they're all very much similar to what you've already seen, very easy to use. So the baseline CRF, you should do that as soon as possible after randomisation. There is the option to come back to it, so you can save what you have and then come back to it. For example, if you have a blood result that isn't available straight away, you can come back and add that in later. There's CRS for the different swabs. The very important 14 and 28 day phone calls. So the way the system's set up, the email address you use to log in doesn't actually give you a reminder, but I will be tracking these and letting you know when your patients are due the telephone follow-up. However, it would be really useful if you have your own system to remember to phone the patients on 14 and 28 days after randomisation. The hospital admission CRFs, you of course don't have to do these for all patients, but as Tim says, you have to fill out one a day for every day they're in hospital. And the forms at the bottom, withdrawal form, death form and SAE form, you might not have to do any of those at all. So it looks like a long list, but actually not all of them need to be completed, and they all are completed on RedCap. Just to talk you through drug supply, so that's supplied directly by Pfizer from their distribution centre in Sandwich in Kent. It's then couriered directly to site, so it doesn't come through us in Oxford, and it's in the usual standard commercial packaging. The CT label, I will provide you with the contents of this label, however it's up to your pharmacy department to print them out. The patient will be taking 2 250mg capsules each day, and the patient will be sent home with 5 boxes of 6 capsules. This equals 30 doses, and the last capsules are surplus to requirement and can be destroyed after the 14-day phone call. Some pharmacies have a requirement to only give the actual number of doses, which is 28, and that's absolutely fine. I've put an example here of the clinical trial label, which will be over-labelled onto each box of azithromycin by the pharmacy, and there's space to include the patient ID on there as well. Okay, can I hand back to Tim now to explain the study treatment?
Brilliant, thanks so much. So just to remind you, this is not being used as an antibiotic. So the indication that we're explaining to the patients is that this is a trial medication which may or may not help reduce the severity of their illness, and they're taking it for that reason and not as an antibiotic. The first dose is to be taken in a hospital in front of a clinician, completing the baseline CRF. So you'll randomise them, you'll go to the drugs cupboard, grab the drug, give it to the patient and send them on their way. Do let them know that every drug has potential interactions, so if they start another drug over the next 2 weeks, then they should let the new prescribing clinician know that they're on this medication. It doesn't particularly interact with warfarins, but it's good practice that any antibiotic which is started in a patient with a warfarin or other coumarin, that they get a repeat INR check in 3 to 5 days. Do let them know that they may get diarrhoea. In fact, this medication is very well tolerated and has a very good side effect profile. Diarrhoea is the main symptom, and that's usually well tolerated and doesn't need to be discontinued. I always warn people when I'm starting long-term azithromycin that if they get any change in their hearing or balance or tinnitus, then they should discontinue the medication, because sometimes it can affect the hair cells. Hearing damage is nearly always reversible, but just warn them. Do let them know that we're going to be phoning them at days 14 and 28. That's really important for our primary outcome. And so it's going to be important that they answer their phone, that they've got a phone that works, and that they're prepared to expect that call. Remind them that there's a study team contact number on the patient information sheet. Let's say they see their GP in the day or two after taking part, then they can also show that sheet to the GP. And obviously, if side effects of a study drug become intolerable, then participants are free to withdraw. So we'll talk about withdrawing from the trial now. According to GCP, a participant can withdraw for a number of reasons in a number of ways. They may choose to withdraw from a trial treatment at follow-up at any time without having to give a reason, but it's helpful to record that reason so we can work out how to improve the trial. They may choose to stop treatment but remain on study follow-up. That's helpful for us. We can still analyse their data. If they stop the treatment during the first 14 days from randomisation, then we will ask them to stop taking the azithromycin because it's an IMP being used outside its licensed indication. Volunteers can withdraw from follow-up and from further communication but still allow us to access their medical records for key data. That's really helpful. They do also have the right to withdraw consent and to ask us to destroy their samples and erase any data we hold. You may also choose to withdraw a participant if you feel that they're completely non-compliant with the protocol, or you found they involved themselves in 3 trials without telling us, or something like that. That's unusual, but the PI is at liberty to do that. But the key message here is that always let the trial team know if a patient wants to withdraw. We'll advise the best course of action, and often a full withdrawal isn't actually necessary. So I'd like to talk about study samples. Key message is that all samples are optional. Some are more optional than others. If we could take one sample, it would be the oropharyngeal swabs. These are going to be tested for SARS-CoV-2 and also for mycoplasma. It is a mycoplasma year. Azithro does act against mycoplasma. We will be asked to present data when we publish this trial on whether we were just treating mycoplasma infection. So we are aware that swab protocols are changing. Certainly a week ago, most NHS patients who were being sent home for ambulatory care were not receiving a study swab. That has changed in some sites and will change. If they get an NHS swab, as long as the data are subsequently available to us to record on the day 28 CRF, then that is okay. However, if they're not getting an NHS swab, please do take a swab. We're providing 1,000 of these swabs with transport media to all sites. They contain a special media which inactivates the virus within 10 minutes and is CDC certified to be safe to handle at category 2 level. This is really helpful. They don't need to be stored in a freezer. They can be kept at room temperature, but ideally in a fridge for the first 7 days. So do let them know that the results of swabs which we take for research purposes only won't be available to them because they're not going to be analysed straight away. They're going to be done in a massive batch of several hundred samples, several weeks' time. We also don't have the IT systems and the GLP infrastructure to get data back to patients in a reliable manner. So if for clinical grounds you need an NHS swab, you need to take an NHS swab and we'll record the data later. These are the study packs that are coming out to you. This is a UN 3373 95 kilopascal bag, which means that if you put the samples in, you squeeze out the air and seal it, it is safe for handling. So your centre are taking 3 samples. So the oropharyngeal swab, it is optional, but it's our highest priority sample. In addition, there are additional samples which are for mechanistic studies. Using these samples which go into RNA lysis buffer, we can measure 33,000 genes. We can perform transcriptomics on airway samples from the nose and do some exceptional science. So it'd be really good if we could get some of these samples, but we would rather that we had your patients enrolled and randomised than get anyone put off because they don't want the samples or because you can't get them done at 2 in the morning in ED. We understand what it's like. So the 2 samples, one is a nasal brush which goes into the blue top tube and one is a blood RNA tempest tube. This little figure I've got on screen at the minute will appear as the desktop on your iPad as an aide memoir, so people will know what to do, which tube goes where. All of them get kept at room temperature or in a fridge ideally for up to 7 days. Next slide. So how would you take a nasal brush? These are for epithelial brushings to do transcriptomics from the airway epithelium. There are no contraindications, but if they've had recent nasal surgery, particularly transsphenoidal brain surgery, I would not do this. Also, if they've got a severe coagulopathy, which does occur in coronavirus, then a nosebleed, if it was induced, would be difficult to stop. And we'd be cautious in markedly deviated nasal septum. Choose an appropriate area for swabbing and take it at the same time as the oropharyngeal swab. This link at the bottom is a link to a funky video produced by the New England Journal of Medicine in the last couple of weeks. It takes 6 minutes to watch. I'm going to run you through it in 1 minute. So next. So put on appropriate PPE according to your local standard protocol being followed in ED at the time. That is not full level 2 PPE in most places. Face mask, a visor, gloves and a plastic apron. Choose an appropriate location for swabbing. There will be one in your emergency department or acute assessment unit. All patients with suspected coronavirus should have a mask on. Ask them to take off their masks, blow their nose to clear the nasal passages, tilt their head back slightly. So ask the patient to close their eyes, it slightly increases comfort. Gently insert this swab just above the floor of the nasal passage until resistance is felt. If you feel that resistance sooner, then back off a bit and reinsert at a different angle. Once you've done that, rotate it 3 times and remove it. Ask the patient to reapply their mask and open the collection tube, and you'll need to cut the plastic shaft in half with disposable scissors. Close the tube, place it in a biohazard bag and send it to wherever your samples are being kept. So just a word about other antibiotics. Antibiotics are not contraindicated in this study, but also they're not usually indicated in viral diseases. And these are the guidelines in Oxford. If you can't exclude community-acquired pneumonia and you're concerned about that and you feel it's clinically indicated to give them antibiotics, then please do so. First line in Oxford is doxycycline or amoxicillin or ceftriaxone. We would exclude people who receive a macrolide. So if you feel you have to treat a community-acquired pneumonia and you're prescribing a macrolide, then they can't be randomised. Also, moxifloxacin and ciprofloxacin and levofloxacin do interact with azithromycin against QTc prolongation, so we would usually not enrol people who are on those. The key thing to say here is that please make the decision about whether or not they need an antibiotic before randomising. We don't want you to randomise them and find them in a control group and then say, well, I better add some doxycycline in to those who didn't get it. You randomise them, you decide on antibiotic treatment first. Azithromycin, if given, is over and above whatever doxycycline or amoxicillin you're receiving. So that completes part 1 of this video. For those who are involved in follow-up, safety reporting and other responsibilities of the trial, there is another short 10-minute video after this. Thank you very much for listening and all the best with ATOMIC2.